Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Muhammad Turki, lecturer of cardiothoracic surgery, Faculty of Medicine, Tanta University. Today we will talk about a very important topic, which is chest trauma that you will face during your stay in the emergency department with its different types, and we'll discuss the types of chest trauma, etiology, and how to manage each of them. Chest trauma accounts for 25% of deaths due to trauma, and is subdivided into blunt trauma and penetrating trauma. Blunt chest trauma can be caused by motor car accidents, which accounts for 70 to 80% of such injuries. Also, fall from height can cause a blunt chest trauma, and acts of violence and blast injuries and occupational accidents. Penetrating chest trauma is divided into low velocity injuries like a knife wound or stab, and medium velocity injuries, which include bullet wounds from most types of handguns, and high velocity injuries that include bullet wounds caused by rifles and military weapons. During chest trauma, we can expect injury to thoracic cage, thoracic organs, and associated organ trauma. Thoracic cage includes ribs, clavicle, scapula, and the sternum. Thoracic organs that can be injured include lung with a pleura on each side, and tracheobronchial tree, esophagus, heart and great vessels, and diaphragm. Associated organ injuries include head trauma and abdominal trauma. Most common thoracic injuries are fractured ribs or sternum, and pneumothorax, hemothorax, chylothorax, cardiac injuries, and diaphragmatic injury. We will discuss together an important notes in chest trauma and how to manage each type of chest trauma. If you are called in the emergency room for a patient with chest trauma, how could you manage? Firstly, you have to take a history from the patient if he is awake and cooperative, or from the relatives if the patient is unconscious or with a disturbed conscious level. The history includes age of the patient and associated comorbidities, type and mechanism of trauma, and timing of the trauma. The type and mechanism of the trauma can give us an idea about the trauma and the impact of it on the patient, and what can we expect to see in chest x-ray, or what can we expect to the trauma can cause in the patient. Timing of the trauma is also very important, because if the patient has a trauma like a stab penetrating trauma to the chest since morning, and he came late at night with minimal pleural effusion, so we expect that the injury is not that severe. On the other hand, if the patient came to the emergency room within few minutes from the trauma with a massive hemothorax, for example, so we can expect that there is an injury to a blood vessel and there is a bleeder inside, and most probably we will need to explore the patient. Clinical presentation. The clinical presentation of the patients with chest trauma varies widely and ranges from just pain to shock. The presentation depends on the mechanism of injury and the organ system injured. Diagnosis of rib fracture. Firstly, there is a localized pain, tenderness, and decrepitness of the fractured ribs. Flail chest is also a clinical diagnosis and confirmed by radiological diagnosis. So, flail chest means fracture of 3 or more successive ribs in more than one point. So, this segment of the fractured chest wall is flail. Normally, during the inspiration, the chest expands to the outside by the respiratory muscles, intercostal muscles, and the diaphragm descends downward to increase the negative intrathoracic pressure to give a chance to air to enter to the tracheobronchial tree, then to the lung to help oxygenation of the blood and aeration of the alveoli. But during flail chest, the opposite does occur. So, normally during inspiration, there is expansion of the chest wall outside to increase the negative intrathoracic pressure, and during expiration, the passive return of the respiratory muscles to its position, normal position before inspiration, will cause positive intrathoracic pressure so the air can be exhaled outside. That's in a normal situation. In the flail chest, the flail segment is not supported by the respiratory muscles and is not in continuity with the rest of the thoracic cage. So, it is not an actively acting part of the thoracic cavity, and it's passively acting one. So, during inspiration, the negative intrathoracic pressure developed by expansion of the chest will cause suction of this flail segment inward, which is paradoxical movement and is not the normal one. And during expiration, the positive intrathoracic pressure will push this segment outside, which is also a paradoxical one. This movement is a paradoxical movement, and it will affect the hemodynamics of the patient. And usually it's associated with underlying lung contusion, because usually it's caused by a strong or a violent accident or severe trauma. In this X-ray, we can see here the fractured rib with loss of continuity of the borders of the rib. Here there is disruption of the continuity of the borders of the rib with the other side. So here we see this is the rib, the normal one, and here this is the fractured one, with this area showing the fracture. In this X-ray, we can see how to calculate or how to count the ribs from posterior to anterior. Usually the ribs are coming from posteriorly from the thoracic vertebrae and directing anteriorly and downward to merge or to articulate with the sternum anteriorly. So the direction of the ribs is directing downward, forward, and medially. So the posterior part of the rib is higher than its anterior part. If we're trying to calculate here, to count here the ribs, so this side, the right side, the counting in front of us is the counting of the ribs at the posterior part of the rib. So this is the first rib, this is the second rib, and this is the third rib, fourth, fifth, sixth, seventh, eighth, to 10th ribs and 12 ribs. On the left side here, we can see the rib counting in anterior part. So this is the first rib here, this is the posterior part, and its continuation here is the anterior one. So the borders of the first rib are here. This is the first rib. And this is the second rib anteriorly, this is the third rib anteriorly, and this is the fourth rib anteriorly. If we see here, the first rib posteriorly is here, and anteriorly is here. So the posteriorly is a higher level than the anterior. This is how to count the ribs. During inspection of a chest X-ray of a polytraumatized patient, we have to follow each rib from its origin posteriorly to its insertion anteriorly, or to its end anteriorly at its articulation with the sternum. So we have to follow each rib from posterior to anterior. Okay, first, second, third, fourth, fifth, and we can check, or we can see the border of the rib and its continuity. If there is disruption at any point, so here is the fracture rib. Definition, etiology, and management of pneumothorax, hemothorax, chylothorax. Firstly, definition of pneumo, hemo, or chylothorax means collection of that thing in the pleural cavity. For example, definition of pneumothorax means collection of air in the pleural cavity. Hemothorax means collection of blood in the pleural cavity. Chylothorax means collection of lymph or chyle in the pleural cavity. Clinical presentation of hemothorax, chylothorax, and pneumothorax. Also, we will follow a scheme. Any collection in the pleural space, if it's significant, it will cause dyspnea because it causes lung collapse. The underlying lung collapse is the reason of that dyspnea. And chest pain, of course, because of the trauma. It may be just contusion to the chest wall, or maybe fractures. So it will cause chest pain in both conditions. Okay. Signs. If there is collection in the pleural cavity around the lung, there are fixed signs. We can see it, like decreased movement of the chest wall, which is present in pneumothorax, hemothorax, chylothorax, because the lung is not expanding in this side, so it will not result in movement of the chest wall at that side. On percussion, there is a difference. If there is a fluid accumulation in the pleural cavity, it will cause dullness on percussion. On the contrary, if there is pneumothorax, that means air in the pleural cavity, it will cause resonance on percussion. In all conditions, hemo, chylothorax, or pneumothorax, the lung is away from the chest wall because it's collapsed. So we will detect a decreased or absent breath sounds on the traumatized side. Okay. Tachycardia and hypotension in cases of shock. So let's see what will be the clinical presentation of pneumothorax. For example, firstly, symptoms will be dyspnea and chest pain. Signs will be decreased movement of the chest wall on that side, and hyperresonance on percussion because it's air, and decreased or absent breath sounds because the lung is completely collapsed under the air, and tachycardia, hypotension in cases of tension pneumothorax. What's the meaning of tension pneumothorax? Tension pneumothorax is collection of the air inside the pleural cavity with shifting of the mediastinum to the opposite side. So the air in the pleural space is under tension. It's a big or massive amount of air inside that will cause a tension. That tension causes shift of the mediastinum towards the healthy side. Clinical presentations of hemothorax include symptoms, as we mentioned, dyspnea, chest pain, signs, decreased movement of the chest wall, dullness on percussion, because it's blood in the thoracic cavity or in the pleural cavity, and decreased or absent breath sounds, and tachycardia, hypotension in cases of shock. That happens if there is massive hemothorax or a big amount of blood in the pleural space. Clinical presentation of chylothorax. The symptoms include dyspnea, chest pain, signs also decreased movement of the chest wall on the affected side, and dullness on percussion with decreased or absent breath sounds, and tachycardia, hypotension in cases of shock. We have to mention something regarding pneumothorax. Pneumothorax has different types. It may be open pneumothorax, like in case of traumatic thoracotomy, or like penetrating wounds with an open wound to the air. That's called open pneumothorax. Another type is called closed pneumothorax. In this one, the fracture ribs or the stab will cause an injury to the lung with a source of air that causes pneumothorax and collection of air in the pleural space, but it's not continued with outside the chest wall, and it's called closed. If the injury causes one-way valve, so the air can enter in the pleural space and it cannot exit outside, so the pneumothorax will collect and will be massive pneumothorax and will be under tension with the shift of the mediastinum to the opposite side. So, what's the difference between the closed pneumothorax and tension pneumothorax? Is the shift of the mediastinum to the opposite side in cases of tension pneumothorax. Investigations in case of chest trauma. Firstly, we have to do a plain chest X-ray. Usually we do it posterior anterior if the patient can stand, so we do it posterior anterior. We can detect the chest wall fractures, pneumothorax, which appears as jet black translucency, or hemothorax, which appears as homogeneous opacity obliterating the costophrenic angle and rising towards the axilla. We can also detect heart and great vessel injury, like enlarged cardiac silhouette in case of precardial collection or precardial effusion, and a widened mediastinum in case of aortic dissection or mediastinal hematoma due to the injury. In this X-ray we saw it before. Here is a fracture rib. This is another X-ray we saw also, and how to count the ribs. In this X-ray we can see here the right side shows a well voluminous lung, normal one, and on the left side there is a fracture rib here. As we see, there is discontinuity between the two ends of that fractured rib with obliteration of the left costophrenic angle and rising to the axilla, and that's called hemothorax. Mostly we can say it's a pleural effusion, mostly hemothorax. Why? Because of the fracture rib. In this X-ray, we can see here the jet black translucency on the right side with underlying lung collapse. Here, this is the border of the lung, and you can see here also the diaphragm on the right side, the right cupula of the diaphragm is pushed downward by the pneumothorax because it's under tension, and you can see here that is a tracheal air shadow is shifted to the other side, so the mediastinum is shifted to the healthy or the normal side, and here is a jet black translucency. So with the shift of the mediastinum, so it is a case of tension pneumothorax. This is another X-ray showing homogeneous opacity, obliterating the costophrenic angle and rising towards the axilla on the left side. This is another X-ray with jet black translucency and a fluid here. Its opacity, homogeneous opacity, obliterating the costophrenic angle, but it's not rising to the axilla. And here, this one, we call it the air fluid level. That means there is hydropneumothorax, and this shadow is the shadow of the underlying lung collapse. Here is the normal or the healthy side with the lung, and there is bronchovascular markings as we see here. So this is well expanded lung, and here is the jet black translucency, and this is a hydropneumothorax with collapse of the underlying lung. The next important investigation in a patient with chest trauma is chest CT. It's better to do it with contrast if the patient does not have any contraindications to use the contrast. This is the chest CT. In this one, the right side is here on this side, and the left side is here. Here also the right side is here and the left side is here. So in chest CT, this is the anterior, this is the posterior, and this is the right side, and this is the left side. We have two windows in the chest CT. One of them is called the mediastinal window, which is this one, because we can see all the mediastinal structures and injury of each of them if present. But we cannot see the parenchymal injuries or the parenchymal, the lung I mean, the parenchymal means the lung injury. Okay, so we can see here, this is the aorta, A indicated aorta, ascending aorta, and here is the pulmonary artery, P, and this one is the superior vena cava. This is the trachea, and this is the descending aorta. Okay, so you can see here clearly the mediastinal structures and the great vessels with the dye inside. So this is a CT with contrast showing the mediastinal structures. In this side, this is called the pulmonary window or parenchymal window. So you can see here the lung parenchyma. If there is a collection, if there is a lung problem like abscess, like whatever, we can see it in this window. Okay, in this window we cannot see the mediastinal structures clearly as this one, so we have to detect both windows to see the injury inside, either parenchymal or mediastinal. Chest CT scan has a high sensitivity to diagnose pneumothorax, hemothorax, lung contusion and atelectasis, and aortic dissection. In this X-ray, you can see here, this is right side as we mentioned before, this is left side, and this is right lung, This is the left lung. This is a cardiac shadow. Okay. Here we see the jet black translucency. Means that there is pneumothorax on the left side, and this is the underlying lung collapse. This is another X-ray showing chest trauma mainly on the left side, the obliteration of the left costophrenic angle. That means that there is left-sided pleural effusion. This is a CT of the previous patient. We can see here the pleural effusion on the same side, on the left side, as we see here. Okay, there is minimal, and here is almost normal side, no collection, and this one is the hemothorax. Okay, but it's a mild amount, it's not that much. This is the parenchymal window or the lung window, pulmonary window of the same patient, that shows here that there is some sort of lung contusion in this area, this area, this area, here also the same, underlying the hemothorax on that side. So we see the previous one. Here is a cardiac shadow and the dye inside in it and in the great vessels. Here is the aorta. Here is the ascending aorta, Here is the pulmonary artery. Here is the descending aorta and superior vena cava. Here is also the same. Then we go for cardiac chambers. This is a mediastinal window showing us the mediastinal structures. And this is a pulmonary window showing us the lung contusion. This is the bone reconstruction of the same patient, the previous one. Okay, during doing the chest CT, we can do what's called reconstruction for the bone to see clearly if there is fractures. It will be more evident. As we see here, this is the thoracic cage, this is the sternum, sternal body, manubrium sterni, the left clavicle, right clavicle, left scapula, right scapula, and here are the ribs on the left side. As we see here, there is a fracture here, 1, 2, and 3 ribs. Okay, that's the fractures on the left side of the patient with the hemothorax, with the left mild hemothorax on the previous slides. Also, CT is very important to differentiate between the encysted and free pleural effusion. Free pleural effusion means that the pleural effusion is present in the pleural space, the effusion is present in the pleural cavity freely and is not encysted or collected in a certain bucket. But encysted pleural effusion means that the effusion is inserted in a certain bucket and is present in an encysted bucket and is not freely distributed in the pleural space. This is another X-ray of a patient, 60 years old patient presented at the emergency room with severe chest pain of sudden onset. This was his chest X-ray. As we see here, this is a cardiac shadow. This is aortic knuckle. And here we see like opacity causing widening of the mediastinum here, which is not normal. In this CT, we see a dissecting thoracic aneurysm. The chest X-ray shows widening of the superior mediastinum and well-defined mass inferior and contiguous with the arch of the aorta. In this clinical context, this section of the arch of the aorta has to be excluded. CT thorax in this patient shows the presence of an aneurysm. Usually this is the aortic arch. Usually it's not like that. Usually the aortic arch is like that here. It's the same caliber almost. Okay, but here that's called an aneurysm because it's the distended part of the arch with a hematoma here beside, so we can suspect a dissecting thoracic aneurysm. Dissecting means that there is leakage from the aneurysm causing peri-aortic hematoma or a thrombus that will causes a widened mediastinum in the chest X-ray. So if we see widened mediastinum in the chest X-ray, we have to do CT chest with contrast to exclude a grade vessel injury. Other investigations in chest trauma include thoracic ultrasound to check if there is hemopericardium and if there is associated injuries. For example, they can give us a comment on the diaphragmatic movement on both sides to exclude if there is rupture of the diaphragm during trauma or no. Lab investigations include blood type and cross-matching, CBC, complete blood count, arterial blood gases, and coagulation profile, which is very important before any manipulation or any intervention that will be done to the patient. To check if the patient has a coagulation problem before the trauma, we have to put in consideration to correct it before any intervention. Investigations of a patient with chest trauma with pneumo, hemo, or chylothorax. So we have firstly to check the chest X-ray, to do CT and CT chest, and other investigations may be needed. For example, investigations of pneumothorax, the chest X-ray will show jet black translucency, as we saw before. Computed tomography or CT chest will show differentiate encysted pneumothorax from emphysematous bulla. Sometimes the emphysematous bulla in the chest X-ray can give a similar picture to an encysted pneumothorax, and the CT scan can differentiate the encysted pneumothorax from the emphysematous bulla. Also, CT scan can detect apical bullae in the primary pneumothorax. Primary pneumothorax, which is not a traumatic one and is called spontaneous pneumothorax, that happens due to presence of spontaneous bullae, apical bullae in the lung. One of them may rupture spontaneously without trauma, without anything, and causes spontaneous pneumothorax. In this case, CT scan can detect other bullae in the apex of the lung, and sometimes this patient may need intervention to exclude this bullae or resect this bullae to avoid another attack of spontaneous pneumothorax. Other investigations include arterial blood gases. This is a case of tension pneumothorax that we explained before. And this is a CT of another patient with a left pneumothorax, but it's not a tension one, but just simple pneumothorax. Investigations of hemothorax include chest X-ray, which show us homogeneous opacity obliterating the costophrenic angle and rising towards the axilla. CT scan of the chest will be done if there is suspicion of encysted effusion and to detect underlying pathology. And other investigations like aspiration and the analysis of the effusion and aortogram. Aspiration and the analysis will show us that it's blood, so we have to do an intervention, and also aortogram, CT aortogram, that will visualize the aorta completely from its origin to its end and will show us if there is any aneurysm or dissection in the aortic wall. Investigations of chylothorax include chest X-ray that will show homogeneous opacity obliterating the costophrenic angle and rising towards the axilla. Computed tomography that will show if you suspect an encysted effusion and to detect any underlying pathology also. And other investigations after aspiration and the analysis of the chyle. If the triglyceride to cholesterol ratio is more than 1:1, so it's chylothorax. Another important investigation, if we detect the triglyceride more than 110 milligram per deciliter, so it is a chylothorax. This is pleural effusion on the left side, maybe hemothorax, chylothorax, according. And this is hydropneumothorax we saw before, air fluid level. This is a pneumothorax on the right side with a jet black translucency here. This is another X-ray after insertion of the chest tube. The lung is fully expanded. So, what's the treatment of chest trauma? As always in any trauma, and management begins with establishing airway, breathing, circulation. So we all know A, B, C, D, and E. Rib fractures. Treatment of rib fractures include effective pain control, either using oral or parenteral analgesic agents, or intercostal nerve block, or epidural analgesia. Early mobilization and aggressive chest physiotherapy. So the patient with chest trauma should have proper analgesia to help him to mobilize early and to help him to do chest physiotherapy to avoid accumulation of secretions inside the tracheobronchial tree, which may cause a problem like atelectasis or chest or lung infection after that. Flail chest, as we mentioned, it means involvement of 3 or more consecutive rib fractures in 2 or more places. So the 3 consecutive ribs or more are fractured on more than one side, 2 sides or more, which produce a free-floating unstable segment of the chest wall. And we mentioned the mechanism or the pathophysiology before. Treated as fracture ribs with proper analgesia and physiotherapy associated with pulmonary contusion. So we have also to give a treatment of a pulmonary contusion, which include a proper oxygenation following the blood gases of the patient 1 or 2 per day, and avoid excessive crystalloid fluid and keep the patient on the negative balance. All of these are the treatments of pulmonary contusion. Keep the patient on a negative balance. Always keep the patient. Negative balance means that the urinary output is more than the fluid intake during the 24 hours. So we have to keep the patient on a negative balance and do fluid restriction. And if the patient needs fluid, we have to give him colloids not crystalloids, because the crystalloids will increase the contusion or will increase the fluid in the lung and will not help in resolution of the contusion. Sometimes the patient may necessitate to insert an endotracheal tube and positive pressure mechanical ventilation. The positive pressure mechanical ventilation idea is to support or to fix the flail segment from inside by the positive pressure ventilation. Also, we may need to fix this flail segment or of the chest cavity or the chest wall, from outside. So we fix it from inside by positive pressure ventilation with inflation of the lung, and from outside by using a plaster and the backing on it. The pulmonary contusion, as we mentioned, needs pain control and to help the patient to do chest physiotherapy, pulmonary toilet, and supplemental oxygen, and we need mechanical ventilation if the blood gas is deteriorating, if the arterial blood gas results is deteriorating. Injury to tracheobronchial tree usually need thoracotomy and repair of the injured trachea or bronchus with a direct intervention to suture if there is any injury, and should be diagnosed before using bronchoscope. So if there is tracheobronchial tree injury, we have to diagnose it. Usually it's associated with a pneumothorax, with a collapsed lung, and after insertion of the chest tube, the air leak is massive and the lung is not expanding, so we have to do a rigid bronchoscope or fiber optic bronchoscope to detect where is the injury to the tracheobronchial tree, and usually the patient needs thoracotomy and repair. Treatment of pneumothorax includes general measures like supplemental oxygen and chest physiotherapy. Specific treatment for a pneumothorax includes chest tube insertion, thoracotomy and repair of the cause. So if there is massive air leak, massive or persistent air leak more than 7 days, we have to do thoracotomy and repair the cause. The cause may be either a large tear in the lung, parenchyma, or the tracheobronchial tree that will cause massive or persistent air leak. Persistence means more than 7 days air leak in the chest tube. Also, video-assisted thoracoscopic surgery, which is a less invasive through a small incisions. We can do an intervention to control the source of pneumothorax. Treatment of pneumothorax. General measures include blood transfusion if the patient is in shock and lost a lot of blood, and chest physiotherapy. Specific treatment include chest tube insertion that should be wide bore one and in the dependent area. Wide bore one to avoid its obstruction by blood clots, and in a dependent area to allow drainage of all the accumulated blood in the thoracic cavity. Sometimes we need to do thoracotomy and repair of the cause of the hemothorax if there is massive hemothorax. Massive means more than 100 ml initially on insertion of the chest tube, or if there is clotted blood. Clotted blood means that the patient does not evacuate all the effusion inside, and after insertion of the chest tube, the chest X-rays still show opacity on the same side of the trauma. That means that there is a significant amount of blood that is clotted inside and needed to be evacuated. Video-assisted thoracoscopic surgery, which is a less invasive, can also be used to manage the reason of hemothorax. Treatment of chylothorax. General measures for chylothorax. Firstly, we use TPN, which means total parenteral nutrition, and nothing per mouth. So the patient nutrition is totally parenteral. The chyle is formed in the abdomen, collected in the cisterna chyli under the diaphragm, which then forms the thoracic duct. By oral feeding, the GIT will work and the chyle formation is increased. So the idea from total parenteral nutrition is to decrease the chyle formation. So if there is a small tear in the thoracic duct in the chest, which is leaking chyle or lymph in the thoracic cavity, can be spontaneously healed or sealed after stopping feeding per mouth. So that's the idea, that the patient will need a total parenteral nutrition to decrease the flow of chyle in the thoracic duct, so we can give a chance for spontaneous healing. The next step is chest tube insertion to drain the chyle and release or relieve the dyspnea developed by lung collapse. If that failed, we can use a thoracotomy and repair of the cause, which is usually a supradiaphragmatic ligation of the thoracic duct through right thoracotomy, through a right low thoracotomy. And that is done if the drainage is more than 1,500 ml per day for 5 days of chyle. Okay, so if the drainage is more than 1.5 liters per day for 5 days chyle, so we have to do thoracotomy and repair of the cause by ligation of the thoracic duct from its origin in the chest just above the diaphragm by right thoracotomy. Another one is a video assisted thoracoscopic surgery for ligation also of the thoracic duct, which is a less invasive maneuver. Cardiac injuries, which may be either penetrating or blunt. The penetrating cardiac injury usually causes cardiac tamponade because the cardiac chamber is penetrated, so the blood will leak from it to outside in the pericardial cavity, which is formed of the fibrous pericardium, which is a tough one and it's not expandable and may lead to tamponade. So what's the definition of cardiac tamponade? Definition: it means accumulation of fluid in the pericardium resulting in marked increase in pericardial pressure and then decreased cardiac output and hypotension. Because the increase in the pericardial pressure will compress on the superior vena cava and inferior vena cava and right atrium, right ventricle, and prevent the venous return from coming back from the whole body, and hence decreasing the cardiac output and causing hypotension. The clinical diagnosis of cardiac tamponade, there is what's called Beck's triad, which composed of firstly hypotension because of decreased cardiac output, and distended neck veins because of compression on the cardiac chambers, which decreases the venous return and hence congestion of the neck veins, and lastly distant or muffled heart sounds because the heart is away from the chest wall by the blood accumulated in the pericardial cavity and separating the heart from chest wall, that causes the heart sounds to be distant. Investigations include chest X-ray that may reveal a flask-shaped cardiac shadow, and echocardiography, which is diagnostic for the hemopericardium. Treatment: if we did just precardiocentesis with removal of small amounts of blood, results in immediate hemodynamic improvement in cases of tamponade if it's present. And next thoracotomy or median sternotomy with pericardiotomy and surgical repair of the cause in case of trauma. So, cardiac tamponade may happen in case of trauma and may happen in other cases. It's not related to trauma. For example, some renal patients, hepatic patients, and other patients with generalized anasarca, they have a collection in the pericardium of fluid. The fluid may be serous, okay, or maybe pus, biopericardium, for any reason. In these patients, just aspiration of the fluid will release the dyspnea and will improve the general condition of the patient if it's tamponading. Okay, so the tamponade can occur in a medical case or in the trauma patient. In the trauma patient, it's usually due to hemopericardium or massive hemopericardium, I mean. Okay, so in cases of trauma, we know that there is blood accumulated inside. So when the source of the blood is from the heart because of penetrating trauma, for example. In this case, we have to explore the patient and check for the reason of the collection of the blood and repair it. For example, if there is a stab wound with injury of one of the cardiac chambers, we have to open and repair that injury. Which approach is best for pericardiotomy and surgical repair in case of hemopericardium? That depends according to the injury. Sometimes we use a left thoracotomy or median sternotomy. Usually median sternotomy gives us a good exposure to most of injuries of the heart, but sometimes we may need to do a left thoracotomy, which is better in some cases according to the site of the trauma or the stab wound, for example. Blunt cardiac injuries, which is mostly causing myocardial contusion, that ranges from mild trauma associated only with transient arrhythmias to rupture of valve or interventricular septum or myocardium, and in this case it's called cardiac chamber rupture. So a blunt cardiac injury can cause only myocardial contusion or maybe rupture of a valve or interventricular septum or myocardium. Management of myocardial contusion. Clinical manifestations range from chest pain to cardiac tamponade and shock. According, if there is a hemopericardium causing tamponade, there will be shock. ECG may reveal arrhythmias or ST segmented changes. Echocardiography may reveal disturbance in the cardiac wall motion because of the contusion, or may detect septum rupture, interventricular septum rupture, or valve injury. Treatment in case of cardiac contusion is usually conservative. Diaphragmatic injuries. Diaphragmatic injury is more commonly diagnosed on the left side, perhaps because the liver obliterates the defect or protects it on the right side of the diaphragm. 84% of diaphragmatic injuries are on the left side, 14% on the right side, and 2% bilaterally. Diagnosis by either clinical presentation, which include pain, respiratory distress, and abdominal complaint. Pain due to trauma, respiratory distress because the ruptured diaphragm may cause the abdominal contents to pass upward to the thoracic cavity because the intra-abdominal pressure is usually a positive pressure and the intrathoracic pressure is negative pressure. So if there is defect in the diaphragm due to its rupture, it will cause the abdominal content to pass from the abdomen to the chest and compress the lung, and so it's causing respiratory distress. Abdominal complaint may be due to the strangulation or obstruction of the intestine because the intestine now are in the chest, for example on the left side, and maybe colic. The patient may feel colic, maybe constipation, maybe strangulation may happen, maybe volvulus. The intestinal loops may rotate around itself, causing its obstruction. That's the reason of the abdominal pain. Delayed cases usually presented with intestinal obstruction or gangrene. That's because the intestinal herniation to the chest wall, to the chest cavity through the diaphragmatic opening. The diaphragmatic opening or the ruptured part of the diaphragm may cause strangulation of the herniated intestine in the thoracic cavity. So gangrene may happen. So gangrene may happen to the intestinal loops. Treatment: direct repair using heavy, non-absorbable sutures like Brolin sutures, either through laparotomy, which means an abdominal incision if the rupture diaphragm is early, or through thoracotomy, which means a thoracic incision if it's late presented or it's not accessible through a laparotomy. Usually, if the patient is early presented, a laparotomy is better for the repair of diaphragmatic defects because the intestine can be easily pulled through the abdominal incision, and the surgeon can detect the defect in the diaphragm and repair it easily. But in chronic cases, if the patient presented late, we expect that there is intrathoracic adhesions between the intestinal loops and the thoracic contents. So we have to do thoracotomy, which is better, to dissect the intestinal contents from the thoracic contents, and we can reduce the intestinal contents easily in the abdomen and then repair the diaphragmatic defect. Thank you.